Welcome to fourth lecture in the series of lectures on medical genetics in Pakistan. This event is sponsored or co-sponsored by Pakistani Society of Medical Genetics, University of Health Sciences, Lahore, and Janassin Medical University. I have some housekeeping items that I wanted to share quickly, and then I'll hand it over to our speaker for the day. Some of the housekeeping rules are to please stay on mute while the participant or while the speaker is talking the whole time, and please add any questions that you might have to the chat box. And at the end of the talk, we will post the questions to Umbreen, and Umbreen can then answer your questions at the end of her talk. And I will be posting a link to a Google form in the chat box. Please fill that form out, because that is the only way we know how to keep track of participants and your feedback and other pieces of vital information. So please take a time to fill it out either during the talk or after the talk, or whenever you get a chance to fill that out. That would be all from me, and I'm going to stop sharing my screen and I'll hand it over to Umbreen Khan. Umbreen, you're on.
Assalamu alaikum, everyone. I will be sharing my screen with the presentation. Thank you for being here today. Is everyone able to see my screen okay?
Yes, looks great.
So as Aisha introduced me, my name is Umbreen Khan. I am a genetic counselor, and today I will be talking about genetic counseling for benign hematology. I currently practice in Salt Lake City, Utah. You can see it on the map. It's kind of in the middle of nowhere, but it does have a big cancer center called Huntsman Cancer Institute. The bottom picture is the campus I work at. It's affiliated with University of Utah. And I currently provide genetic counseling for cancer genetics as well as benign hematology as part of Huntsman Cancer Institute and University of Utah. I have no conflicts of interest to declare. The objectives of this talk are description of benign hematology disorders and irresponsible genes, implications of these conditions for Pakistan, purpose of genetic testing for these disorders, discussion of the role of genetic counseling, as well as challenges in genetic testing, as well as important considerations. To start off, some of the common benign hematology disorders that I'll be discussing during this talk are 2 or 3 clotting disorders and the hemoglobinopathies. So you may be familiar with the most common clotting disorders called hemophilia A and hemophilia B, caused by the F8 and F9 gene mutations, and von Willebrand disease caused by the VWF gene mutation. Hemoglobinopathies include alpha thalassemia, caused by the HbA1 and HbA2 gene mutations, beta thalassemia, and sickle cell anemia, both caused by mutations in the HBB gene. So I'll go back and forth with coagulation and clotting, both meaning the same, disorders that disrupt the body's ability to clot blood. Coagulation disorders can result in either a hemorrhage, so too little clotting that causes increased risk of bleeding, or thrombosis, too much clotting that causes blood clots to obstruct blood flow. Hemophilia A and B, as well as von Willebrand disease, make up 95% of all coagulation disorders. How does this relate to Pakistan? So almost 80% of world's hemophilia population exists in nations with limited economic and medicinal resources. Hemophilia A and von Willebrand disease are common congenital bleeding disorders in Pakistan, and there may be lack of diagnostic facilities, and when there is a lack of diagnostic facilities, there may not be proper management available to these that are tested for infections such as hepatitis B, hepatitis C, and HIV. And according to a study in Pakistan, blood donors were known to have a prevalence of various infectious pathogens that range from hepatitis B, hepatitis C, as well as a small percentage of donors with HIV infections as well. Some of the symptoms of clotting and bleeding disorders include bruising easily and excessively, extreme fatigue, frequent nosebleeds, prolonged bleeding from cuts or surgeries, heavy menstrual cycle, joint pain caused by internal bleeding, as well as sudden pain, swelling, or warmth in joints and muscles. Von Willebrand disease is a condition that takes its name from the clotting factor protein in the blood called von Willebrand factor. Mutations in VWF gene can lead to low levels of von Willebrand factor, leading to excessive bleeding. It can be inherited in both autosomal dominant and recessive manner, and it affects all racial and ethnic groups. Genetic testing is not routinely done for von Willebrand disease, at least here in the United States. Hemophilia is another genetic condition that is caused by defective factor VIII and factor IX proteins. These proteins are generally helpful in clotting the blood, and they occur in the body, but when there's a defect, the blood clotting process is slowed down. There are two types of hemophilia, hemophilia A as well as hemophilia B. Hemophilia A is caused by mutations in the F8 gene, and hemophilia B is caused by mutations in the F9 gene. Both of them are inherited in X-linked recessive manner, and the prevalence is about 1 in 5,000 males affected with hemophilia A compared to 1 in 30,000 males affected with hemophilia B. There's thousands of unique variants in each of these genes that causes hemophilia A and B. And majority of these are single nucleotide variants or single gene mutations instead of larger deletions and duplications. For hemophilia A, intron 22 inversion is the cause of 45% of all severe cases. And in hemophilia B, large deletions and duplications are usually rare, but if they are present, they're mostly new changes. Hemophilia A and B also affects all racial and ethnic groups equally. So who should consider genetic counseling for hemophilia? Male patient who is affected with hemophilia and has a daughter should consider having his daughter's factor levels checked before her first menstrual cycle or at the time of surgery. Offering genetic testing to an affected male is usually optimal. Female patients with a family history of hemophilia should also consider their factor levels checked, especially prior to surgery or pregnancy. And if their factor levels are not within the standard range, they may consider meeting with a genetic counselor, such as a prenatal genetic counselor. What genetic test to order? So for F8 deficiency, patients who have severe F8 deficiency, you would start with inversion testing from intron 22 and intron 1, and reflex to full gene sequencing. From mild to moderate F8 levels, you would start with full gene sequencing and can reflex to a deletion duplication analysis if that is necessary. For F9 deficiency, the primary test would be sequencing of the gene, and you may reflex to deletion duplication if that testing is negative. So what is the purpose of genetic testing in this scenario? According to the World Health Organization, genetic testing is recommended for all individuals with hemophilia A as well as hemophilia B. Factor levels in females are less reliable for carrier testing than molecular testing. So genetic testing would be the only most reliable way to know if a female is a carrier for a mutation in one of the genes that would increase her risk to pass it down to her offspring. There is new data coming out that says that specific mutations can then be used to predict if there's a risk of developing inhibitors. And inhibitors are basically inhibitors can develop in somebody's body that can make it so that the medicine that they're taking to help with the clotting does not work anymore, or is not as effective. There could also be options for targeted molecular medicine. There's 3 different types of results that we can get with any genetic testing, including hemophilia testing. There's the pathogenic or the likely pathogenic result. There is the likely benign or the benign result. So pathogenic, likely pathogenic, meaning we found a disease-causing mutation. Benign or likely benign, meaning we did not find a disease-causing mutation. And then the 3rd type of result is a variant of uncertain significance, or VUS. A VUS result simply means we don't have enough information about that specific change to know what it really means at this time. In 90% of the cases, a VUS result is reclassified to meaning not disease-causing. So we treat a VUS result like a negative result when we're managing patients. And for that reason, we would not encourage female carriers to have their medical management based as a carrier if they have a VUS result. Additionally, if a pathogenic variant is identified in one family member, at-risk carriers or males can be tested for that specific gene mutation as well. So you can see the genetic test report on the slide here, and the summary of the results here says the test results were negative. It was targeted testing, and if you are able to see, it may be very small, but the clinical history says that this is a healthy female who's unaffected. Previous testing in another laboratory identified a variant in the F8 gene in her mother, and therefore targeted testing was requested for this specific patient. So if you already know what variant's in the family, you could do targeted testing for that variant. And the variant in this person's family is a likely pathogenic variant, which they were negative for. Some of the genetic counseling considerations when counseling patients with hemophilia with or without genetic testing are that a woman who has a son and a brother with hemophilia is an obligate carrier. A woman with 2 sons with hemophilia is also an obligate carrier. And a woman whose father has hemophilia is a known carrier. Additionally, 1/3 to 1/2 males have no family history of hemophilia and are the only person in the family affected with hemophilia. When a woman has a son with hemophilia, there is about a 4 in 5 or 80% chance that the woman will be a hemophilia carrier, a 1 in 5 or 20% chance that she would not. For a new or index case, either the proband would have a de novo or a new mutation, the mother could have a de novo mutation, or the mother could have a mutation she inherited that occurred in only her father's sperm. That is, her father had germline mosaicism. So here's a case example. The pedigree indicates that the patient that presenting to the clinic did not have genetic testing, but did have a history of heavy periods. Her sister is a carrier, so the patient's chance to be a carrier is 1 in 2 or 50%. So this would be something you would talk to them during pre-test counseling session. And then given that the patient's great-grandfather was affected with hemophilia and her sister is a carrier, the chances that the patient's mother and grandmother are known carriers is 100%, taking into consideration that both of them potentially had the same mutation. It is unlikely that the great-grandfather's hemophilia is unrelated to the hemophilia then tracking down in the family. And we can see that women are generally not affected with hemophilia. They're usually asymptomatic. The next bleeding or clotting disorder / the hemoglobinopathies is thalassemia, which is part of a blood disorder called hemoglobinopathy. It is caused by a defect in the gene that helps control the production of globin genes that make up the hemoglobin protein or molecule, rather. And there are 2 main types of thalassemias. There's alpha thalassemia, and then there's beta thalassemia. How do thalassemias relate to Pakistan? In Pakistan, literature suggests that there's 1 to 4 per thousand infants who are born with thalassemia, which makes it one of the high-risk countries for thalassemia in the world. There's not a current disease registry in Pakistan for thalassemia. However, the national carrier rate is around 5 to 7%. So approximately 10 million infants are affected. The main preventative strategies for thalassemia include appropriate information of the disease, importance of screenings through awareness programs, screening and counseling of target families, screening of general population, as well as premarital and prenatal screening. Some of the symptoms of thalassemia can include fatigue, weakness, pale or yellowish skin similar to jaundice, facial bone deformities, slow growth, abdominal swelling, and dark urine. Alpha thalassemia is caused by mutations in the HBA1 and HBA2 genes. It is inherited in an autosomal recessive manner, and it occurs when a gene or genes related to alpha globin protein are missing or changed, i.e. mutated. It is most commonly found in Southeast Asian and Middle Eastern populations, as well as African, West Indian, and Mediterranean populations. The alpha globin is made by 4 specific genes or alleles, 2 on each strand of chromosome 16, and different forms of alpha thalassemia can occur if 1 or more of these alleles are missing. So the chart here describes what happens or what type of phenotype a person may have if they have 1 or multiple of the alleles missing. So if there's 1 allele missing, they're usually a silent carrier, meaning they don't generally have any symptoms. They can still pass it down to their offspring, this 1 missing allele. They could be a minor alpha thalassemia, which means they have 2 alleles missing, and the 2 alleles could be in trans or in cis. And they're also usually asymptomatic, and their hemoglobin electrophoresis results would be normal or within range. People could have HBH disease when 3 out of the 4 alleles are missing, and they would have moderate to severe hemolytic anemia. On hemoglobin electrophoresis, you would see HBH. And then the most severe type of case of alpha thalassemia would be hydrops fetalis, which is when all 4 alleles are missing. That is usually incompatible with life. And on hemoglobin electrophoresis, you would see HB BART. Beta thalassemia is caused by mutations in the HBB gene. It is inherited in an autosomal recessive manner as well. And it occurs when a beta globin gene is changed or mutated so that the production of beta globin protein is affected. It is most commonly seen in Mediterranean and African populations, but can also be seen more commonly in Southeast Asian, Thai, and Chinese populations. The beta globin gene is made by 2 specific alleles or genes, 1 on each strand of chromosome 11, and different forms of beta thalassemia can occur, similar to alpha thalassemia, if 1 or more of these alleles are altered. So the key difference here is the alteration versus the missing alleles. For beta thalassemia, the minor or the beta thalassemia trait would be when you have 1 beta thalassemia allele and 1 beta thalassemia plus allele, or 1 beta thalassemia allele and 1 beta thalassemia 0 allele. Beta thalassemia plus means that there is a mutation that causes the allele to not function at its full capacity. So the beta globin genes are not produced in the amount that would normally be produced if there was no alteration. The beta 0 means that the allele is not functioning at all, so no beta globin gene is being produced. In either one of those cases, generally, the person who has this alteration is unaffected or asymptomatic. Then there is beta thalassemia intermedia, which is beta plus, and there may be variable degree of severity. The third and the most severe is major beta thalassemia major or Cooley's anemia, and that is when you have a beta plus and a beta 0 allele, or a beta 0 and a beta 0 allele. This would usually present within the first year of somebody's life with severe anemia, growth delays, enlarged organs, deformities of their skeleton, and transfusion is usually required within 2 years of their life. Sickle cell disease occurs when there is a very specific mutation in the HBB gene, also known as HBS or p-glutamine 6-valine, right at the top here. And then there could be any other mutation in combination with it. It could be HBS, HBC, or a beta thalassemia mutation in the beta thalassemia gene, that is. The symptoms of sickle cell disease could include bone pain, chest pain, fever, stroke, abdominal pain, painful swelling of hands and feet. And on a physical exam, you may see enlarged spleen, jaundice, pallor, joint pain, and on an x-ray, you may see fish mouth vertebrae. Usually their blood counts are within range, or they have microcytic anemia. They may have high reticulocyte count and peripheral blood smear sickling. They're usually diagnosed by hemoglobin electrophoresis or peripheral blood smear or molecular testing. And on hemoglobin electrophoresis, you would mostly see HBS. You may see hemoglobin F as elevated as well. So generally, to do a workup for thalassemia, you would see if a patient has anemia or decreased MCV count, then you would do ferritin or iron studies. If their iron is low, then it's likely iron deficiency that's causing the anemia. But if their iron is normal, then you would be more suspicious of thalassemia minor, because if they're not having any other symptoms other than just anemia, it's unlikely that they have any of these severe forms of thalassemia. After you do that workup, you would do hemoglobin electrophoresis or HPLC. Either options are valid to see what their hemoglobin levels are. And depending on if the hemoglobin A2 levels are elevated above 3.5%, you may consider beta thalassemia minor or alpha thalassemia minor as the differential diagnosis. You could not diagnose alpha thalassemia minor without doing gene testing for them. So you would have to do gene testing to see if they have alpha thalassemia minor or beta thalassemia minor. So for alpha thalassemia, you would start with targeted gene deletion analysis for some of the common deletions. If those are negative, you would sequence the gene, and if new mutation, deletion analysis. For beta thalassemia, you would do the complete sequence analysis of the gene itself, and that causes most of the known beta thalassemia mutations. Rarely you would find a deletion duplication in the HBB gene. Majority of the labs would do that sequencing and del-dup analysis concurrently, so at the same time. So if that is available and it is more cost effective to the patient, that would be the route you would choose to go. So why pursue genetic testing? It is to determine if somebody is a carrier and to then provide them with some guidance in terms of their reproduction, as well as family management and their own medical management. A known gene mutation can provide guidance for prenatal diagnostic testing. You can also help a family establish a diagnosis for an individual or a family, and to understand the underlying cause of anemia in a patient if their blood count values are in borderline range. So why is genetic counseling important? On the left hand slide, the blue boxes highlight some of the barriers or some of the challenges that may come up when you're offering genetic testing. So the cost may be an issue, the availability of the testing may be an issue, finding people who are experts could be an issue if the person is in a rural area where medical centers are not available to them readily. Interpretation of the results could also be an issue, and then the ethics of genetic testing can come into play as well. So in terms of addressing those challenges, having a genetic counseling session, pre-test session, as well as post-test session is important. And then in terms of the ethics specifically, pre-test counseling of patients or asymptomatic relatives could address several issues, including the severity of the disorder, the implications of the potential results so that the family is prepared, and then the discussion of medical management, appropriate referrals needed. So when the results are back, the family knows that they're in good hands and they know exactly what the next steps would be for them. Additionally, there could be prenatal diagnostic testing, so testing using amniocentesis or chronic villus sampling during pregnancy to see if the fetus is affected, and that could also run into ethical issues of its own. So here's a mnemonic that can be helpful when you're thinking of some of the genetic counseling considerations or issues. It's called determine. So you develop experience with testing labs and data interpretation. You establish a rationale for genetic testing. You think about the VUS and the incidental findings and how you may communicate those to the family. You engage the patient and the family members. You relate the phenotype of the patient with the genotype and vice versa. You must consider implications of genetic test results for the patient as well as their family. Interpret test results with the support from a multidisciplinary healthcare team. You should never ignore ethical issues, cost, family values, as well as patients' right to autonomy. And you should engage the patient in the genetic testing decision-making process so that the patient is invested in the testing as much as the healthcare provider or the healthcare team may be. One of the things that I would like to point out in terms of engaging the multidisciplinary healthcare team is that there may be a lot of healthcare providers that can provide care to patients with hemophilia as well as thalassemias, including physical therapy, social work, physicians, hematologists, genetic providers, nurses, etc. And so it's truly really important to provide care by utilizing all of the resources so that all individuals are included in the medical management of these patients. So here's another case example. A 45-year-old male patient presents with mild anemia and borderline MCV and MCH counts. The hemoglobin value was 13, HbA was 93%, HbA2 was 4%, HbAF was 3%. So if you notice, the MCV and MCH values are kind of borderline, the HbA2 is elevated, and the workup that we looked at before, if it's elevated above 3.5%, that's when we consider or think about thalassemias. The referring physician is suspicious of beta thalassemia. So how do we determine if somebody has relatively normal red blood cell count and there's no really any other indication that they may have iron or B12 deficiency anemia based on their presentation? The only really way to determine if they have beta thalassemia would be to offer genetic testing. So here are some of the references that I used for this slide. And with that, I'm grateful for all of you for listening, and I will open the floor for questions. And here is my email address as well, if any of you wanted to reach out.
Thank you, Ambreen. That was wonderful. I don't have any questions from the chat so far. So if anybody has any questions they want to post to Ambreen now, please put them in the chat box and I'll be happy to read them to Ambreen. In the meanwhile, while we're waiting for folks to type up their questions and send them over, Ambreen, I wanted to ask a couple of questions for myself. You've taught me a lot today about different benign hemoglobinopathies. Just share with me some of your experiences, if you would like, of a particular case that comes to mind that was the most striking to you, and how do you think genetic counseling helped that family? Thank you.
Thank you for that question, Aisha. So I work with the Hemophilia Treatment Center at University of Utah, and we have a lot of cases of individuals who don't have a diagnosis, even, you know, they don't have genetic testing done, and that was not something that was available to them. I think the common theme with all of those, or a lot of those patients, is the cost of genetic testing. So hemophilia is one of the most one of the earliest genetic conditions that was identified, but genetic testing for hemophilia still remains something that is unlikely covered by insurance, or there's a high out-of-pocket cost. And so that makes it really hard for families here to access genetic testing or genetic counseling. So my goal has been in the past year and a half to really try to justify this testing for family members and help with that testing. And a specific case was when we had a patient that did not have a diagnosis, an established diagnosis, and they knew there was something wrong, but they couldn't figure out what was wrong. And I worked with them. I provided pre-test counseling and talked about what type of results we can get and if we can potentially find an answer. And that was really helpful for them in giving them some of the control back, so that they can feel like they're not just imagining these things in their head, that there's actually something going on. And then when we did the genetic testing and I was able to justify the testing through their insurance, having a genetic provider to justify that testing was also really important. And when the results came back and there was a known mutation in one of the genes related to hemophilia, they really felt validated that they weren't just imagining all these pains and muscle pain and joint pain, and their heavy bleeding patterns were because of this condition. So having someone like a genetic counselor talking to the patients from the beginning to the end can be really important, because one, it can prepare the patients, it can also prepare them emotionally for the results, but it can also provide them with the validation they need, so that then they can feel like there is someone who may be there as they're going through the journey of this diagnosis. The other important part of genetic counseling is that we work with a team of doctors and other providers who specialize in these conditions. So while my expertise lie in genetics, it is really helpful to have a team of experts like hematologists and other physicians and physical therapists, social workers to really help the patient. So I think that is also important, that you have a team, including genetic counseling, to help the patient. I hope I answered your question there.
Yeah, that was wonderful. Thank you so much for that. Now, there's a question from Hira Iqbal. She would like to know, I honestly don't know the answer for this myself, so I will just post it to you. And this is related to Pakistan. She wants to know, is there any government body offering genetic testing or prenatal testing in Pakistan for any of the benign hematology disorders you just talked about?
I would open that question to people who currently practice in Pakistan, because I feel like I'm not an expert in answering that question from, being not in Pakistan. From my small literature search, I know there was a pilot program in Multan where they attempted to do the screening, but I would love to hear if somebody else who's more of an expert than me can answer that question.
Yeah, we can open for individuals that are experts on this on the call. If anybody wants to share their thoughts, that would be great. In the meanwhile, I'll look up another question. So, where is this? All right, so we have one more question. This is from Muhammad Abbas, and he would like to know, we don't go for exome in case of thalassemia. How many genes and variants so far are known?
So going back to the initial slide, there are roughly 1,000 to 2,000 variants known for each of those genes. The reason why we don't do exome is because if we know that the person is likely going to have some sort of thalassemia, doing an exome would not, one, be cost effective to the patient depending on the cost, but also can come back with a lot of incidental findings. So findings that the patient may not necessarily expect. An exome could find things like breast cancer genes or other cancer genes, which aren't something that the patient is expecting. And we don't know if that is information the patient would really want. So this is where patient autonomy would come in, their decision to know the information that they want to know about their genetic testing. And if an exome is done, we may find things that the patient isn't ready or the patient doesn't want to know, and can open a door for a lot of misinterpretation of results as well. So the most efficient way would be to do targeted gene sequencing and deletion duplication analysis of that HB A2 and HB1 gene, as well as the HBB gene.
Yeah, great. Thanks, Ambreen. I think that was a wonderful answer. I just wanted to make sure that it was clear that thalassemias are caused by two genes only. And within each of those genes, there could be, like Ambreen said, almost 2,000 variants that could be disease causing. So I would, again, want to make sure that there's an understanding of a distinction between what is a variant and what is a gene. So gene is a long stretch of DNA, and within the long stretch of DNA, there are variations that can cause the gene to not perform its function like it's supposed to. When you talk about whole exome sequencing, you're talking about hundreds and thousands of genes being analyzed at the same time. And really, when you don't need to, when you know what the phenotype, you know what the symptomology is, you really don't need to go for exome sequencing because you're not looking for thousands of genes. You know which two genes could possibly be at play, and you test for just those two genes. So hopefully that clarifies that. And Dr. Ahmed would like to say a few words. So Dr. Ahmed, if you'd like to unmute yourself now, please go ahead.
Thank you, Aisha. Thank you, Aisha. Thank you, Ambreen. This was a great lecture. I'm Dr. Ahmed. I'm a geneticist here in Riverside, California. Ambreen, if you can go back to your slide of the workup of patients with thalassemia. So I wanted to ask if, we're talking about screening of women in Pakistan for thalassemias. Uh, would you agree that the cheapest form of screening for women would be just to do a CBC and start with that process? Because most of those patients will have a low MCV, so you don't have to go to genetic testing. So if all pregnant women just get a CBC, which I think they do most of the time, and the doctors, if they have that in the back of their mind, because iron deficiency anemia is very common there as well because of the poor diet. So if they could start with microcytic anemia and follow this table that you have, that probably would be the easiest and cheapest screening method for these patients in Pakistan. Would you agree with that?
Absolutely, I agree. And I think that, yes, so the CBC count would be ideal. And then the hemoglobin electrophoresis could be the next step before you jump into genetic testing. And that would generally be the cheapest. So yeah, 100%, that is probably the most accessible if you're doing it for a large population.
So generally big OBY centers can implement this as a thalassemia screening method for all the patients that they're seeing by starting with this, which is very, very cheap and easy accessible test, both of them. Thank you.
There is also another question that came up about video recording. So just a PSA, all of the videos from all of our lectures are available on our website at www.psmg.org, and you can go back and watch it as many times as you like. So I just wanted to make that public service announcement. Let's see.
It seems like, oh, sorry, Aisha. I just saw that there are some screening mechanisms or screening things in Pakistan at Fatma Jinnah Medical College, as well as Gangaram Hospital.
Oh, that's great to know. Aisha Ashraf had made a comment on chat box also saying that according to her knowledge, there are no screening programs as such at the government level. Some, like you said, some hospitals might be doing it on their own population, but there's no broad newborn screening program or prenatal screening program that does that. Ali Amar has a question as well, and they want to know how common and informative is the pharmacogenetic testing for hydroxyurea drug response in beta thalassemia in the United States? Do you educate about upcoming or futuristic therapies like CRISPR-Cas9 as well?
So since I'm not a medical doctor, I do not talk to patients about medications. So that is not in my wheelhouse. But in terms of talking about futuristic treatments, CRISPR-Cas9 is not something that is used currently. We do talk to patients as a genetic counselor about specific mutations, literature search of those mutations, and then the risk for inhibitors, which is when the medication may stop working, as well as any search that may be related to targeted molecular therapies, but that would not include CRISPR-Cas9 specifically. If anyone else on here knows more about the pharmacogenetic testing for that specific drug, please feel free to answer.
Yeah, if Dr. Ahmed wants to unmute himself and respond to this question, that would be great.
No, I'm sorry, I don't have much experience with that because most of these patients are treated by hematologists and they use those pharmacogenomic testing to treat those patients. So we don't see them in our clinic for this type of testing. So I don't have any comments on that. I can look it up and let you guys know.
All right, great, thank you. So
Mila had a great question, Aisha. I just caught it, and her question was about why is there a high prevalence of AIDS in people who have hemophilia? So I briefly touched on this in my slide, but oftentimes, even here in the US, we have a lot of older patients with hepatitis as well as HIV, and that is because the blood that they receive as part of their transfusion treatment is usually or was not historically tested for active viruses. And that is currently an issue here as well in Pakistan, less so here now that we know more than in Pakistan. But that is one of the main reasons why a lot of older people with hemophilia as well as thalassemias may have AIDS or hepatitis infections as a comorbidity in addition to their current diagnosis, which then makes it even harder for them to get care. It causes stigma, and a lot of people don't actually, understand that the HIV or the hepatitis infection would be due to the transfusions and not due to any other practices that people may generally associate with those viruses. So that is a great question. Thanks for bringing that up, Mila.
Yeah. I'm not seeing any other.
I have a question for Amreen. Amreen, since there are a lot of consanguineous marriages in Pakistan, do you have any comments on screening for patients who can afford for carrier screening that would include screening for blood disorders as well? Do you have any comments as to what's available in the US and how much is it for? And Aisha, maybe you can chime in so our guests can know that those options are available, that they can do blanket screening for prenatal patients for certain common carrier disorders.
So I know that for thalassemia, since they're autosomal recessive, and that causes the high prevalence in Pakistan because of the consanguineous marriages, there is carrier screening available here, and it is recommended, especially if a couple is consanguineous or from one of the regions where thalassemias are more commonly seen. The cost of the testing, I think, can be variable. I know it's generally included in like a prenatal screening panel. So Aisha, you work in prenatal screening lab. Do you have a cost? What Natera charges for those?
Good question. I don't know the exact cost because it depended on insurance, and out-of-pocket costs could also vary. Depending on which size panel you're using sometimes and other various different things. But if anybody's interested, they can just go to www.natera.com and look up the cost and prices for that. But what I wanted to highlight is a couple of things. One is that the word consanguineous means cousin marriages. Sometimes it could be a big word. Most people don't know what that means. A cousin marriage is quite common in Pakistan and definitely not something that is unique to Pakistan. There's a lot that if we look at, our current participants, there's almost 50 of you, 70% of you, if you are married, would be married to your cousin. And so there isn't any particular association with consanguineous marriages, because a lot of consanguineous marriages will not have any affected children or relatives. Having said that, if you have a family member who has had a genetic disorder, despite it being, one side of the family or another, ammi ki taraf se, abbu ki taraf se, mamu hai, khala hai, ya chachu hai, ya puppu hai, it doesn't matter. But if you know that a child had concern, before having a cousin marriage, premarital screening for these autosomal recessive disorders should be considered. And this is where genetic counseling can make a really big impact in helping families. Now, as far as which test is best and which test is not best, when we're talking about the next generation sequencing and the rapid improvement in technology of these these carrier screening panels, I think the best bang for the buck comes from the largest panel you can find. And I think we have almost a panel with almost 300 genes that can be tested for. And the cost for that panel is approximately $250 for the first partner that gets tested. If the first partner is found to be a carrier for even one of those 300 genes, the other partner can get tested for $100. So that can help in the reduced cost there as well. And not everyone can afford that. We know that in Pakistan, and we're obviously working towards more improvement in that regard and see how we can help that. But if you have a known family member who has had a child with some sort of genetic disease or hereditary disorder, definitely consider talking to your doctors about a genetic test. Yeah, hope that answered your question. Okay, I'm trying to see if there are any other questions for you, Amreen. So it looks like there are 2 more questions. Dr. Nuzhat Aisha Akram is asking, is pedigree analysis and risk assessment come under genetic counseling?
Yes, absolutely. So in your pre-test counseling, that's what you would do. You would get a full pedigree. You would talk to the patient about the risk assessment. And there's lots of patients that I see in the hemophilia clinic where I don't do genetic testing because we know somebody's a known carrier unless they're planning to have children, or they need that testing for family members. Sometimes they know they have hemophilia and they want to know what the risk for their children is, but they may choose to hold off on the genetic testing. So definitely would assess their risk if somebody is already an obligate carrier, meaning that their son has, or 2 of their sons, for example, have hemophilia, and hemophilia is generally X-linked. We know that it's 50-50 chance that it's inherited from the mom. And if 2 sons are carriers, then the chance that it is the mom who is a carrier is that means that mom is obligate carrier, meaning she's definitely a carrier, because you can't. It would be really hard to have 2 children with hemophilia that are completely new mutation. So yes. The answer is that's what we would talk about in genetic counseling and prepare the family that you're likely going to find a mutation because you're an obligate carrier, but we could still do genetic testing to provide information for your other family members.
Great, thank you so much. Now I have one more question for you, Amreen, and I would have to say that this question takes the award for best question of the day. So you get ready, this is amazing. So this is from Ali Amar. They want to know, how should we counsel someone Example, a potential couple who know they are carriers for thalassemia, but still want to go ahead with marriage because of family pressure. Comments concerning ethical issues without disturbing the autonomy right for them.
That is a really great question. So that's where genetic counselors come in. I think our role is to really assess the family dynamics, bring in other people like other family members, but also bring in other healthcare providers like social workers or psychologists to help with the family dynamic. Now, if a couple wants to get married, say because of family pressure, and they are carriers for thalassemia, we can provide them with information that they need so they can have that information and are prepared if they do have a child with thalassemia. So we would give them the risk if both of them are carriers. What are the risks for having a child with thalassemia? We would, depending, and I'm not giving the numbers because it would depend what type of thalassemia, whether they have the mutations that reduce the penetrance or the make it so that the beta gene, for example, is not functioning at all. And so we would counsel them very specifically about the carrier status, the specific risks for them. And so genetic counseling is what we call non-directive. We never tell patients what to do. We never tell patients what they should or shouldn't do in terms of their decisions for their family planning, for their relationships. Our job and our role is to give the patients as much information as they need so that they feel that they have the power to make the decisions for themselves in terms of their life decisions. And that's where the autonomy comes in. So we would do our best to give the patient all the information that they need. We could help communication between families. So if their parents wanted to have a session with a genetic counselor to talk about these issues, we would certainly be able to meet with the patients, the family, and be able to give that information to them. And so that is a very short answer to a very question that we could probably, and Aisha did a great lecture on ethics last time, but this would be a great case to talk through and see exactly what factors are coming into play when we're thinking about a family like this. But we would never directly tell them, you need to do testing or you shouldn't have children. That is not something a genetic counselor ever does. It is not in our role. It is not something that is our decision to make. And that is why our role is to simply empower the patient.
I love Amreen's answer. So Amreen, the award for best answer of the day goes to this answer as well. Great question and great answer. The only thing I would add to that is the firm stance that genetic counselors take is to not tell patients what to do, and instead empower them to do what they want to do. One example that comes to my mind is we know the frequency of cystic fibrosis in Caucasians is actually very similar to the carrier frequency of thalassemias, beta thalassemia in the Pakistani population is close to 1 in 20 versus 1 in 25 for cystic fibrosis. And we never say to a patient or a couple who is a carrier for cystic fibrosis that they should not have any more children once they are identified. It is their decision on how they proceed with it, whether they are capable or if they have like a financial means to do the in vitro fertilization and take that route to prevent the future children from having cystic fibrosis is a choice at some degree. Choice is a loose word that I use because again, privilege plays such a big role in who can afford it and who cannot afford it. And so again, we don't tell them what to do. We empower them with the resources that they need to make the decision that is right for them. Okay, and now switching gears just slightly, two more points came up. One is from Misbah Hanif. She is actually one of our genetic counselors at the National Institute of Child Health in Karachi. And she's pointing out something really important, which is that if a a couple, like say a first cousin marriage couple, they wanted to know about thalassemia, and they go and get the thalassemia testing done, and that is negative. They then go ahead and think that, you know, we're good to go, we don't have anything else to be concerned about, and we can get married. And they really don't take into regards all the other hundreds of thousands of disorders that could still be possible and could play a role in their reproductive lives. And so she's bringing that up to the providers that are here on this call, to make sure that when you're talking about this with the patients, that you're not only focusing on one autosomal recessive disease, but all autosomal recessive diseases. And the other point that is also coming up in the chat box is from Mohammed Ayman, and they posted a link to a government website, ptpp.punjab.gov.pk, that you could go to, and it's a government-run website. It's a thalassemia prevention program. So we were less informed than Mr. Muhammad here, and he has informed us about some things we did not know. So thank you for sharing that with us. It's very, very helpful and informative. Okay. Wonderful.
I did put my email address in the chat if anyone has any clarifying questions, but you can also email Aisha and she can redirect those questions to me.
Absolutely. And I'm going to share the link one last time for the Google Forms. So for those of you that are interested in participating and getting emails from us, this is our only way of finding that, of sending emails to you. So please feel free to fill out the Google form, and it doesn't take us very long. By the end of the day today, I should be able to email everyone who signs up today and who has already signed up in the past, to provide them with information about today's lecture and the videos and things like that. So please fill out this form. And we're at the top of the hour, perfect timing, and we have exhausted all the questions from the audience. So I want to take this time to thank Ambreen so much for this super informative presentation and thoughtful answers to the questions from the audience. And please visit us on our website at www.psmg.org and fill out the form. And we look forward to seeing you again on our next lecture, which is most likely going to be on oncology genetics. So take care, and Khuda Hafiz.
Hafiz, thank you everyone.